Good morning, everybody. Dr. Gabriele Jasper here, doing our podcast. This is our third podcast, and I like to introduce myself as a MD, physician, interventional pain physician. Interventional pain, a lot of people don't know what interventional pain does, and I'm here to explain it to you and how we can help you. We do a little bit more than pain management. Pain management, sometimes these doctors, they give you a lot of pain medication. That is against our policy and our place. What we like to do is get rid of the pain pills and treat the cause, the pain generator, so that the pain goes away.
Right.
You know, we're not miracle workers, even though some people call us miracle workers, but we do the best we can with the latest technology. And what I do in my place, we try to avoid major spine surgery, because the evolution today is going away from major spine surgery.
Yeah.
We're trying to catch up with the other parts of the world, because, and I always say it, that this country is probably the most backward country, most behind when it comes to spine surgery.
Yeah.
Because of obvious reasons. But going back to what I do, I do interventional pain, which means that we find the generator and we control the pain. And I'll do basic stuff, just to be simple. I do epidural injections. We treat with needles, arthritis of the spine, and we treat a lot of, also intra-articular joints under a strict X-ray or fluoroscopic guidance or ultrasound guidance, all indirect visualization, but precision injections. But my practice is unique because of the fact that I've, over the past over 20 years, have investigated all throughout the world on how to do minimally invasive spine surgery to avoid patients having to get these big spine surgeries.
Yeah.
And it's working tremendously. This is what I'm known for. I'm known all over the United States. I'm known all over the world, basically, because I've trained doctors. I've learned from the best in the world. And after learning, I mean, I'm talking 15, 20 years I've been doing it. Now I teach other doctors how to do it. And it's amazing. It's amazing how through 4-millimeter incisions you can help these people.
Yeah.
And that's what I do. We also have a special guest here today that
we do.
That I like to introduce. And I'm going to say a little bit about him. He's honest, and he has unbelievable hands. He's a spine surgeon. He does the traditional spine surgery, but he's the kind of guy that is honest, and he's not in it for the money.
Yeah.
You know, if you're in it for the money, you start to do things that can make an honest person dishonest.
Right.
He doesn't care about that. He cares about the patients. And the reason I know that is we've known each other 8 to 10 years, maybe 9 years. And we've met each other, and he knows by being very knowledgeable in his field what I do. And he knows what the advantages are on doing the things that I do. Of course, as I always say, when a person needs traditional major spine surgery, I'll be the first one to tell my patients.
Yeah.
There's not too many of them, but I'll be the first one. And it's very hard to find a surgeon that will do what needs to be done. And this doctor, which I'm about to tell you what his name is, this doctor does that. He does what needs to be done without exaggerating and looking at how financially how much more you're going to make if you do it this way. No, it's what the patient needs.
Yeah.
He's got great hands. I've seen him in action, and my patients rave about him.
Right.
Even before we met, they talked good about him.
Yeah.
Well, here he is, Dr. Chris Radcliffe, spine surgeon, and he's going to tell you all about himself, because I'll probably mess it up. At my age, you can't remember everything. You know what I mean?
Yeah.
Here he is, Dr. Chris.
Hey, how you doing,
Hey.
Dr. Chris?
Thank you for that great introduction. I remember. So when I've been in practice for 12 years now. I'm an orthopedic spine surgeon. I did a fellowship at a university at Thomas Jefferson in 2009. And one of my first years in practice, I was honored to be on the faculty at a minimally invasive spine surgery course. And at the time I got to see endoscopic spine surgery. And it was probably the first time I'd ever seen it. And I was really interested in it. And after the course, I wanted to sort of adopt it into my practice. So I did some research. I looked on, in the literature on what we call PubMed to look at publications and who is really publishing. Because if you're publishing, you're probably an expert and really a leader. It's funny because I kept seeing this guy, Gabriel Jasper. And a lot of these, as Dr. Jasper alluded to, a lot of the innovation in endoscopic spine surgery came from Germany and from Asia, from Korea in particular. And this guy was like right up the parkway here in New Jersey. And so I said, I gotta meet this guy, and see what he does and see if it's real or not. Some of my colleagues who do traditional spine surgery are critical of it, and they're critical of it's new, and I think a lot of the same comments are the same comments people probably said when they first started doing ACL surgery with all arthroscope, or doing shoulder surgery with all arthroscope. So yeah, I came up to meet Dr. Jasper and visited him and saw this beautiful facility and a couple of the procedures, and I was blown away. And certainly over the years, in particular, I've sent patients over who've had a great experience likewise, with endoscopic spine surgery and with other procedures. Yeah, I mean, although I'm a surgeon, I really think of myself as just a spine doctor. And I mean, my goal is not to encourage people to have surgery. It's just to get them the right treatment for their problem, regardless of what that is.
Right.
And I think one of the problems we have in spine surgery is just people are worried about their safety. No one's going into a knee scope, or even a knee replacement thinking, am I going to come out of this? Am I still going to have a leg? But when people go into spine surgery, because of probably some true stories and some kind of just, horror stories that you hear about, there are times where people are really afraid and really worried about being messed up.
Yeah.
And I think that's kind of why I think that doing surgery that's less invasive, more precise, more image guided is really the key to helping patients have confidence that this is not going to mess them up, and that in fact, for the right reasons, it can totally change someone's life.
Now, the relationship you have with patients, that's very important to you.
Oh yeah,
Right?
of course, yeah, absolutely. No, I love my patients.
Like the individual patient sitting
Oh
there,
yeah,
getting to
yeah.
know them. Yeah.
Absolutely, yeah. No, it's fun. They become members of the extended family, and like the best is when you see them. If you see patients out just in the community, right outside of like the doctor's office, because no one feels good when they're in your office. But when you're running, I ran into a patient of mine, and we were going into a Bass Pro Shop to do some kind of Christmas pictures and Christmas shopping with my family and my kids. I've got 3 kids and lived there, 3 little kids. And, I've got another patient who, actually baked my daughter's birthday cake this year for her 7th birthday.
That's great.
And another patient of mine painted this beautiful picture that I have on my wall in my office. And, the whole thing was she was a painter, but she couldn't paint before surgery because she had a problem with her spine that affected her hands. And after surgery, she was able to regain hand function, and she painted me a picture.
That's amazing.
That's a great story.
That's a great story.
So yeah, so no, it definitely is. It's an honor and a privilege to be able to take care of people. People are obviously afraid, and there's a bit of vulnerability when they come in to see you, and they put a lot of trust in you as a person and as a doc, and I take that very seriously. I'm not a miracle worker either. Not every surgery goes perfectly, but certainly, I really do enjoy my patients. So, I give patients my cell phone number. I make it a point. I want to be very accessible and available. That's a priority of mine.
I want to just let the audience know what your plans are. All of a sudden now you're coming out on your own, and it's a fantastic thing for new patients. And tell them what situation you're in now, and how these patients how you can help the patient, how they can contact you, and everything like that.
Yeah, so I did my fellowship at Rothman in 2009. I've worked at Rothman Orthopedics for the past 12 years, and I decided to break free of the nest and to go off on my own and start my own solo practice. I love the people at Rothman, and and it's a great practice, but I want to go in a bit of a different direction and have a more, somewhat smaller scale, local kind of dominant practice where I can really offer individualized attention to my patients and be able to, be a little more flexible in terms of just scheduling and visits and to offer really good access.
Yeah.
You
And
gotta,
I think that's really, I'm really excited to do that. I start that October 1st.
the courage for a doctor to come out of a well organized practice, that group practice that will be there for a long time because they have multidisciplinary and a lot of support, to come out on your own for obvious reasons. It takes a lot of courage. It's a big step. It's a lot harder than jumping off a high diving board for the first time.
Yeah, it's terrifying. I'll tell you though, it's funny. I've talked to a couple of my patients. If I see people in the office, I tell them. I've called people as well to tell them. And I certainly was on eggshells at first, like as to whether people were gonna, what they were gonna say, or why are you leaving? I'm not going with you. But I mean, every single patient who I've talked with and interacted with so far has been like, yeah, we want to stick with you. We want to, you're my guy. And it's such an honor, and it really does give me a little bit of comfort as I'm going to sleep at night, thinking, what the heck am I doing?
That's got to lift you up a little,
Yeah.
That's good.
What I like to say about that is we're losing my practice. It's a private practice. I've been alone for a long time. We have a new associate, which is great, but now we're two people, and people miss this. People miss the personal relationship that you have with the doctor. A doctor that goes out on his own does it for particular reasons. We're the type, doctors go into medicine, at least in the old days, because they want to be independent and they want to help their patients, and they don't want anybody telling them how to do it. Of course, when insurance companies kind of dictate a lot of things, it's hard, but we work around that. But it's just us making a decision based on the patient. We look at the patient. We spend time with the patient. It's not going to see a physician's assistant, a nurse practitioner, or medical assistant, physicians. You're seeing the doctor, and that's personal. And there's nothing better than that. And you got to take advantage of something like my practice, and Dr. Radcliffe's practice, and there's very few of them around. In fact, I had some students, medical students, come to my office for externships while they were in medical school, and they're telling me that the future of private practice is gone. And you're talking already 10 years ago.
Yeah.
And I said, no, it isn't. And they said, well, I said, what are you going to do? Well, I'm going to get a job at a big practice or at a hospital. I'm going to work for the hospital. They brainwash these poor kids today. And that's what the administrators at the hospital, this is what they're trying to do. It's not true.
So the dream of them hanging up their own shingle.
Those days they're not over. Here's a perfect example. And Dr. Radcliffe is going to be one of the most successful spine surgeons around because of that reason.
Yeah, I totally agree. There's an AMA survey that over 50% of new graduates are now going off and going into employment jobs where they're working for somebody, and there's kind of this. I think it's multifactorial, like Dr. Jasper said. The medical students aren't getting access as much to community doctors who are outside and unaffiliated because some of the hospitals are closing ranks, and in the old days, primary care physician, if you were in the hospital, could come and see you in the hospital and round on you there. Now, like a lot of the hospitals have kind of closed ranks and said, well, no, if you're in the hospital, you're going to see one of our internal medicine or hospitalist, specialists. And there's probably some value in that and some benefit to that. But from a training and access perspective, I think it does make it harder for some of the med students to see, what it looks like to be independent, to run a business. On top of that, I just think people are afraid. And like Dr. Jasper said, insurance companies beat us up. There's a ton of like kind of just fear. And, it is easier to work for someone else, but I mean, inherently you're giving up some autonomy, and, that could take the form of, like in the worst case scenario, I guess you have some kind of quota of like surgeries you got to do per month. More commonly, it's just like, do you want to have what time do you want to start your day? What time do you want to end your day? Do you want to close your day early because, your kids, starting kindergarten, it's ice cream social,
Right.
and those things, as well as, can you come into the office on a Saturday and see somebody, or can you stop by somebody's house if they're really in bad shape?
Right.
And, if you're on your own, you can do all of that stuff. You can be much more nimble and much more flexible.
Old school stuff.
And you make your own decisions.
Yeah.
It's great.
Did you say ice cream social?
Yeah. Yes.
Did you? Yeah. That's like a
Yeah.
slice of Americana right there.
Yeah. First day of kindergarten on Tuesday.
What comes to my mind? Dr. Radcliffe came to my office to see some of my patients, and we had quite a few patients that. So the fact that I don't send patients to surgeons, that's not true.
No.
I do, and we talked about this for quite a long time, and I had certain patients that I just couldn't help anymore, and they needed a spine surgeon. So I put them on a list to see Dr. Radcliffe. We formed a date. He came in and he saw all of these patients, and I was working that day, and I was in and out, and I was busy, but I managed to get into the room for a couple of reasons, just to see how Dr. Radcliffe works directly. Number one, number two, to make it more comfortable for the patient. They were my patients, and now Dr. Radcliffe's patients. And what was amazing to us, both of us, we talked about this, was we sat down and discussed this patient. We discussed this patient's pathology, what's wrong with them, together, the same pathology, same problem from two different
Angles.
aspects of training.
Yeah.
And it blended together in like a symphony of, we figured things out that I don't know about you, Chris, but to me, when I left that office that day, I said, this is great.
Yeah.
Because you're looking at it from two different angles. And it all makes sense, and you come up with maybe a decision that you might not have done alone.
Right.
You know what I mean? What did you think about that?
Yeah, I totally agree. I mean, there's no way that a successful pain management specialist or anybody can. I mean, you're going to refer patients out for other treatment, for surgery, et cetera, because at times, people just exhaust the measures available, and ethically, you got to set them on. And Dr. Jasper totally does that. But yeah, it really is great to be able to speak with a colleague, speak with somebody who's knowledgeable and experienced, and say, now, how would you tackle that? What would you do in this case? And to kind of be able to look and brainstorm and come up with a plan. It really is, fantastic. And I think it offers a ton of benefit to the patients, because you're kind of getting, like, quote unquote, a second opinion, but you're getting it from two different specialists with two different backgrounds and looking at it through two different lenses.
Right.
It's really nice. And the patients, patients love it. Patients love the idea also of the handoff and the continuity of care. Like it's one thing to say, hey, call this 800 number, or go to this website. It's a whole different thing when you're saying, no, you're going to see my guy, this is what you should do. I think the handoffs are much more seamless and much more smooth.
We got Joanne Reen. She just posted, thanks so very much, Dr. Jasper. Another great result. Thumbs up.
Oh, great.
Yeah, you're going to love that.
Thank you, Joanne. Thank you very much. Anyway, so I think there's a future for our relationship and the relationship with other patients in this area. Where are you located now?
I'm gonna do surgery at Shore Medical Center down in Summers Point, and at the Jasper Ambulatory Surgery Facility in Brick. I'm gonna have office location in Brick and an office location down in Summers Point. And I'm working and getting into the local hospitals in Ocean County to be able to provide some continuity, or if someone has to sort of have a surgery that just can't be done in the surgery center. I currently have privileges at Capital Health Medical Center, which is in Hopewell. It's kind of near the Trenton area, and it's a beautiful brand new hospital that has fantastic facilities, fantastic equipment. I mean, there's a spa in the hospital. You can go get manicure and pedicure while you're there. So
Yeah, that's
it
nice.
is really nice, and I have found that facility has, although it's a little far, it provides excellent care as well, both in the operating room as well as afterwards, for kind of complex cases.
Mm. So you're pretty much right now you're planting your roots locally to,
Correct.
yeah, I mean,
Yeah.
that's great. It's also a really big, what do you call it? What is it? No, I'm
Want to be a little
blanking.
more specific?
Yeah. No, but that, like Doc said earlier, about hanging out that shingle on your door. It's a big challenge. It's a big, and in many cases it's a risk, but it's
Yeah.
great. It's great that we have these strong, knowledgeable doctors. And now we're finding the few young ones that are escaping the hospital's corporate mandates and rules.
My father's 94 years old.
Yeah.
And when he heard about all these, hospitals are hiring doctors and becoming an employee, he said, that's temporary.
Yeah.
It's temporary. They get, and they try to brainwash everybody, but it's going to go back. And here's living proof.
Living proof. Yeah.
Living proof. And you just, and I see it all the time. Doctors are leaving. And I keep going back to this. I remember when I was a kid, my father, he was a very busy practitioner. He was a surgeon. He was a urologist, and I used to go make rounds with him. I used to go to the emergency room with him. I was a little kid, and it was just so cool that he could just get up from the dining room table after dinner and says, "You want to take a ride? I got to go to the hospital," and just go do it. It wasn't like he was going to a job 9 to 5. He was taking care of his patients, and his patients loved him.
Yeah.
And I love that autonomy. You're by yourself and nobody's your boss.
Right.
And that's the beauty of it. No, you can't have my father always said, doctors are like cats. You can't herd cats.
Yeah.
And that's why people take the insurance companies, the administrators, the hospitals, everybody take advantage of it because they're so organized. And you can't even get a bunch of doctors sitting down together, organized to how to defend themselves against these people.
Yeah.
And they take advantage of it.
Yeah.
Because we're independent. But today, you got some of them that would rather just work, but people like me, like Dr. Radcliffe, we're going to survive and we're going to thrive and we're going to help our patients, and patients are going to be very grateful for it.
Yeah, and you're going to hear a lot more about Dr. Radcliffe. I think we're even going to try to set up his own show here on the Catchmore Network. That would be grand.
Yeah, I think that healthcare is definitely best done local, and the best case scenario is for example, in a couple of weeks, I'm taking care of the mother of a little girl who's in my son's class. My kids' friends' parents who are my friends. It's just they know you, they trust you, and it really is. It's so important. So yeah, I think it's important to be have roots in the local community and to be engaged and present, and to make sure that you're available and you meet people. And the best referral, I mean, we've always said this, is it's not a billboard, it's not a Google ad, it's just having some patient say, this doctor took good care of me. This is I trust them. And that's how I pick doctors. If there's somebody I know or I like, I say, who do you trust? What do who would you go to for this?
Yeah.
It's so tough. We as physicians don't know who's, if we don't know them personally or work with them, we don't know who's a good doctor. So can you imagine the lay person out there who knows nothing about medicine, and they go online and they look at people. A lot of times you go online and you see somebody with 5 stars. You wonder, with the technology today, somebody can get 5 stars and not even be that good.
Right.
So it's like you said, it's word of mouth. We do these shows mainly because we want to educate patients.
Yeah.
Patients are out there not knowing what there is to do. For example, spinal stenosis. Spinal stenosis, and Dr. Radcliffe knows the incidence or the amount of patients that have spinal stenosis, it's ridiculous.
Right.
It's an endless reservoir of people who just can't walk. People who have spinal stenosis, they can't walk far. And it's a little bit, we like to talk specifically about certain things because we want to let people know that there's something that we can do for them.
Right.
And spinal stenosis, and this is great because we're going to work together with patients with spinal stenosis. They have these minimally invasive procedures now. They're spacers, right? Things that are done under indirect visualization, where you use the X-ray, the live fluoroscopy, and take out a little bit of the ligament, which is increased in size and closing down the central canal, which causes a person not to be able to walk far. They can't stand up straight. Their legs get weak. They can't go up the stairs. And this is your typical leaning on a shopping cart syndrome.
Yeah.
If you lean on a shopping cart and you can't walk far and you sit down and you feel good, you got spinal stenosis. And I'm sure Dr. Radcliffe would agree. I don't know if I ever read anywhere that spinal stenosis is genetic, but I think it's genetic. What do you think?
Yeah, absolutely. There's a, yeah, I mean, stenosis just means narrowing. People always ask that. It sounds ominous, but it just means narrowing. And you could have narrowing from anything, from a bone spurs, arthritis, disc herniation. But yeah, a lot of people have what's called congenital stenosis, meaning that their spinal canal is not really big to begin with. And that's just kind of how people are, or some people are built. And then, think of a room. If it was like a small room and you had big furniture, it ends up being really crowded. And so people with congenital stenosis, if in this example, like the disc herniations and the bone spurs, even if they're moderate sized, it has a ton of causes a ton of crowding on the nerves and other things because there's not that much room to begin with. So so direct decompression means that you essentially, if there's a room that's too small, you just knock out a wall, or part of a wall, or make a window or something. And you're kind of looking at and removing whatever's putting pressure on the nerves. Indirect decompression means that it's hard to think of a construction example, but it means that you put in something just to make the room bigger. Maybe you raise the roof up a little bit or whatever, so that like you're kind of just creating a little more room. You're stretching tissues out to their appropriate length, and then that way, you're improving the narrowing somewhat. Sometimes indirect decompression works, sometimes it doesn't.
Right.
But it's certainly, in general, the indirect ways are less invasive than the direct ways.
Yeah.
I mean, and this is one of the reasons why we're going to have a good relationship, because Dr. Radcliffe understands that, and he's not in it for the money. I've had patients where I put spacers in, or I decompress the structures that are easy to decompress, and as he said, open up indirectly the area. And believe it or not, the majority of patients do fantastically.
Yeah.
Because you don't need a lot. These patients have been suffering for years, and you just take a little bit out, or you just open it up a little bit, and they do fantastic, like they were 10 years ago. And what's better than that? All right, maybe 5 years down the road, you might have to do a little something again,
Right.
and then they get good again for 5 years. But I've sent patients to doctors that I thought I trusted, to just open it up a little more, that I can't do
Right.
on these patients. And they do major fusion, multiple levels, and the patients come back and they're worse than they were, where at least they were able to sit down and feel good. But a lot of these patients don't feel good even sitting down anymore. So you got to know who to send it to. And this is some of the things we discussed when we saw these patients, and how Dr. Radcliffe would like to do certain things and not go crazy, and he knows that they're going to be good.
Yeah.
And work it together. It's going to work out.
Yeah.
Less
A good doctor knows, like, what to do, and then of course not what not to do.
Yeah.
And that's important as well. Go ahead, Chris. I'm sorry.
Yeah, I think it's important, that, like, in many cases, less is more. And as long as people know, we're going to try this. This is plan A. If it works, great. If it doesn't work, then we'll do plan B, which is a little more, and plan C, which is a little more. I think that's kind of part of the sort of the part that the patients have to trust us and accept that, like, if you want the full major complex surgery that will remove all your stenosis, that's fine, but there's a price to pay for that in terms of the recovery and length of time and risk and all that. So yeah, I think that's really important. That sometimes it is kind of a staged approach, and there is a bit of trial and error, which is guided by educated guessing and by experience and by literature and stuff.
It's, it's amazing that that it is like that. It is trial and error. It's a process of elimination, and it's all for the benefit of the patient. And you try to explain it to them with kid gloves because tell the patient, all right, we're going to do this. If this doesn't work, what are you talking about, doc? You don't know that? It's not an exact science.
Yeah.
You know, it's not like a mechanic building a carburetor. You know, you change the parts and it's fixed.
Yeah.
You know,
But everybody's carburetor is different.
yeah,
Right. Yeah.
yeah. And another on this subject is the fact that, as Dr. Radcliffe's alluded to, was that patients need to be educated. They need to understand. They need to. But the problem is, I get some patients from doctors, local doctors, that they gave them an epidural, and then they come to my office, and I'm like, "Well, what happened with the epidural? It only worked for 3 days." I said, "Well, why don't you go back?" He goes, "Didn't work." What is the problem there? I hope none of these doctors are listening, because if they listen to this, they're going to change their way and they're not going to come to me. What they need to do is sit down and talk to the patient. I talk to the patient. I look at the MRI. I already know that this patient is never going to be 100% pain-free for the rest of their life, no matter what you do. There's nothing that's going to happen. It's not, I'm going to go get this fixed once and for all. It doesn't work like that. You got a bad back. You have to have realistic goals. Your spine is messed up. Not everybody, but the idea is not to go crazy and destroy the rest of your life. If you do a little of this, a little of that, and you get better, and then maybe you get a little worse again, you fix this. This is the evolution of it's a progressive disease.
Yeah.
Degenerative disc disease, which is the root of all evil.
I've got it.
Is a root of all evil, causes everything else in your spine. It's going to continue to go down. And one day somebody's going to figure it out. In fact, I'm sure you know about this. They're working with the genes. They're finding people who are that inherently go into degenerative disc disease more than other people, because maybe they're lacking an enzyme, which is they're talking about, if we can incorporate this enzyme in the person, but this is the future to prevent the disease. That's way in the future. It's not in our lifetime. But the idea is you need to have a doctor who can explain to you, like Dr. Radcliffe said, we're going to do this. If this doesn't work good enough, we're going to do this. You got to go step by step, and you got to let them know. You sit down and talk. Of course, you're spending more time with the patient. There's other patients probably complaining that they're waiting, but that's the whole purpose of treating the patient the right way. They need to walk out of their office confident that you're going to help them. And if, God forbid, the first procedure doesn't work, they're not going to go somewhere else and know that there's something else, because they already know and they understand. And that's the key to a good relationship with a patient.
That's what you explained to me, and that was a nice sizable chunk of knowledge to follow around with, because I have to be careful, but I also have so much freedom that you've given me. But I also understand that I have a bad back, and I always will, so you gotta be a little careful,
Yeah, I think the key is that, like Dr. Jasper said, a couple things. There are really well done studies in from Europe and actually in Utah, in the Mormon population, that where there's kind of long-term genealogy, that genetic factors probably account for about 50 to 60% of the likelihood of getting degenerative disc disease. So in most cases, you can thank your parents or grandparents. In particular, in one study in Europe that I remember, the investigators looked at a group of identical twins who had different occupations, and the question is, is it the work? Is it one is a laborer, one's in an office, that causes the disc to degenerate, or is it the genetics? And overall, there was about a 40 to 50% match in, this twin has a problem in L4-5, that twin has a problem in L4-5. That was explained by genetic factors, even in people with different occupations. So I totally agree. I think the other part that I want to just touch on is if you look at the literature, even people who don't have symptoms have bad backs if you look at the imaging. It's hard for people to get that and grasp that. They say, well, I don't hurt. How could I have had a bad back? But what happens is the studies, the MRIs are so detailed that they can pick up abnormalities, even if they're very early, very subtle, before they're causing symptoms. So then, when you look at your MRI report and there's like kind of all these words and, the stenosis at this level and degeneration here, and it sounds ominous, it's important to have in the back of your mind that context of, well, this is something that's common and often doesn't cause people any problems. And so the goal isn't to get you a perfect MRI report. It's to get you to a level where you're not going to have problems.
Yeah, that's the old saying that we learn, at least most of us learn, you don't treat the MRI, you treat the patient. And just on the other extreme, Dr. Radcliffe's talking about how terrible your MRI could be, and you read it because you got a little bit of pain in your back, and you're like, oh my God. And somebody might even tell you, oh, you got a back like an 80-year-old and you're only 40 years old. But on the other extreme, we get some, and Dr. Radcliffe could attest to this, we get some patients that have severe pain, and they got severe radicular pain, sciatica pain going down the lane. You look at the MRI, and you're like, holy crap, where the hell is this coming from? Is this patient malingering? Are they faking? But now, if you really know how to read an MRI, right, and you look, like I had one yesterday, a patient with exactly what I'm talking about, and went shot all the way down to the foot. And I looked at the MRI, and if you know how to read an MRI, I saw that the tunnel, which is a neuroforamen L4-5, on the right side, was about half the size of the one on the left side. But in my opinion, you shouldn't have pain with it because there was still plenty of room in there. But patients still, it depends on the patient. It depends on the nerve. Maybe the guy hit the nerve somehow. Now the nerve swelled up like a balloon. And in this particular patient, he went to 2 doctors and said, there's nothing wrong with you. And I saw that there was something wrong. And I gave the patient an injection, like a selective nerve root block at that level. Pain went away 100%.
Yeah.
I got to see him in a couple of weeks. But that proves that that's the problem. So you could have somebody that looks like the perfect back, but if you know how to read an MRI, you could find it.
Yeah.
It's something simple. That person, once that nerve shrinks down, probably never have a problem until they hurt themselves again.
Right.
You never know. So it goes both ways.
The other thing is the MRI, the reports. I mean, the MRI reports are done by the radiologists, and they're doctors who are experts at like looking at the pictures and calling abnormalities. For the most part, the radiologist's goal is to be complete and thorough and to call everything. The lens that we have to look at this through as treating doctors is a little different. We want to focus on what's causing the problems, what's causing the symptoms. And I think sometimes, I think it's critical that surgeons and interventional pain specialists can critically look at an MRI and can decide for themselves, this doesn't look right, this looks fine, so that you kind of know what you're aiming for. So whenever I see people, I always ask them, hey, please get a disc. I want to see the pictures. I don't just want to see the report.
Yeah, that's a standard rule. My people at the front desk tell them that.
Yeah.
They say, don't, you got to bring your MRI. And what's good about today, most of these places, we can get it right in the office.
Yeah.
They don't even have to bring it. But that's a class with that patient that I was talking about. Perfect what you just said. If you read, these patients are reading their reports. They don't know what they're reading half the time, but the report said it's negative, there's nothing wrong. But we as physicians treating the patient, not just the MRI, had that pain going down the leg. And I said, I got to look at 4-5. I got to really look at 4-5 because we know the dermatome distribution. We know if the patient has pain down to their calf or ankle, they're going to have probably around 4-5. And if it goes into the foot, you got to think about 5. So I look at it. And when I saw it, which, like you said, the radiologist is looking at everything in general, and there's always a little abnormality. They don't talk about everything. Well, I honed in on it, and I looked at it, and I found it. It was putting pressure on the L5 nerve at the lateral recess and a little bit of the L4 nerve, and there was the pain. you know. So you got to treat the patient, not just the MRI.
Yeah, totally agree.
Yeah.
Couple of the things that I think are interesting are, neck problems can cause neck pain and cause arm pain and so forth. But the other thing that some people sometimes don't immediately connect, I think for the listeners, is if you're having trouble with balance or with finger coordination, that can be a sign of a neck problem. Now, there are a lot of other things that can also cause balance problems, like diabetic neuropathy and, and other stuff. But if you're having that, if you're having trouble with your balance, trouble with your finger coordination, jewelry, buttoning buttons, handwriting, that kind of thing, it probably is important to have someone take a look at your neck, because that can be a part of it, even if you don't have neck pain, even if you don't have arm pain. We call that myelopathy. And I'll tell you, we like one of the interesting stories is we did this study at Jefferson with a couple of the medical students, that like people who fall down and have hip fractures, for example, are much more likely, when you dig into it. Well, like they say, well, I felt, oh, I've been falling for a while. And a lot there's a pretty high incidence of neck problems, like even in people who fall and who receive healthcare for other reasons. And you got to just be careful and think critically and say, well, wait, I know how to treat the hip fracture, but why did they fall in the first place? Do we need to look at the neck or something?
That's another great, and I keep saying yesterday. It's funny. I had a patient yesterday that came back after I gave him. I sent him for an MRI of the cervical spine. He went to other doctors, and he said he went to 2 other doctors, and one of them, he had a little bit of pain. He got a little bit of spinal stenosis, not bad in the lumbar spine, and he had some sciatica. I'll say sciatica around the air. People understand that better. And they got a shot in the lumbar spine. But his major complaint, he came to me and said, I can't walk. I walk, I have no pain. And I joke around. I said, did you see the sign in front of my building? What do you mean? What's that? The one that says pain doctor? Doesn't say I can't walk, weak leg doctor. I always get a little chuckle out of him. But if you listen to, just like Dr. Rackler just said, if you listen to the patient, nobody sent them for a cervical MRI. And it was classical symptoms of somebody who might have stenosis in the cervical spine. Because it's hard to explain. It's better off in person to explain what the symptoms are. And the reason I'm talking about it now is because the people listening might think that they have this and they need to get checked. Nobody thought about doing an MRI of the cervical spine. This guy had weakness in his legs, but more than weakness, he didn't know where his legs were. He didn't know where his feet were. He had not full muscle strength because he's older and weak, but he said he would trip and fall and not understand why he was doing it. And sure enough, he came back and he had moderate central canal stenosis at C5-6, and everything else was good. He just had a degenerative disc disease with a bulge on one side and a big facet joint, and the way it was. You look at the axials, with cross section, it was surrounded completely, choking the spinal cord. He didn't have any obvious myelomalacia, as they call it, in the spine, but it was hurting. So he doesn't have any permanent damage yet. And what happens is, and I explained to the patient that the muscle nerves, the nerves that go down to make your legs move, are very strong. They're insulated. So the electrical impulse is going to go down pretty smooth and pretty fast. But the nerves that come back up, that are very fine nerves, they're not insulated. The sensory nerves, the proprioception, the nerves that tell you where your legs are very slow at that point. And so what happens is when he's starting to walk, he moves his leg forward, and he thinks his leg is already forward, but it's still back there somewhere. So then all of a sudden, he doesn't know where he falls because the leg isn't there yet. So he's getting ready to lean that way. I mean, it's hard to explain, but a good phenomenon that I do often in my office before I send them, just to prove to them it's probably coming from their neck. I tell them to walk down the hallway and look straight up. Don't look at their feet. They're kind of wobbly. We're all over the place. I said, now walk across the hallway looking at your feet. And when they look at their feet, their brain registers where their feet are all the time. It doesn't happen all the time, but all the time, the brain knows where their feet are, and all of a sudden they walk normally.
Right.
Because you got to watch how they don't walk into a wall because they can't see where they're walking. But sure enough, the guy came back and we diagnosed it. And I was thinking of you. I'm going to send him to you.
Yeah, for
You
sure.
got to open that up. How extensive is that opening up? Like, I guess you got to look at the MRI.
Yeah, it depends a little bit on the MRI, but no, I think what Dr. Jasper said is totally accurate. The spinal cord, if you think about like walking or even, I mean, like even you're trying to button a button or something like that, or pull something out of your pocket, it's pretty complicated from an action perspective. I mean, to walk, you gotta feel the ground underneath your feet. You gotta feel where your trunk and where your sort of your center of gravity is when you're moving. And then it has, so there's some sensation that has to come, and then your body has to kind of like put the feet down in the right sequence and the right cadence so that you're upright and moving safely. And all of those things are kind of done without you having to actively think about it. Like Dr. Jasper said, like we walk around all the time. We don't usually think about, all right, I'm going to put my foot here, not unless you're walking on hot sand at the beach or something.
Right.
But essentially, when your spinal cord doesn't work properly, when it's damaged, then that coordination is lost, and then all of a sudden you have to cheat and look at your feet because you can't rely on the normal sensation to tell you where your body is in space.
I have diabetic neuropathy as well as what, like a twinge nerve damage would it be, or no?
Well, diabetic neuropathy is because of the fact you have diabetes, and it starts to work on the peripheral blood vessels, the small ones, and the peripheral nerves.
Yeah.
And as long as all your life you've kept it in check, most people will not get it. But the people who don't keep it in check, they'll get it.
Well, there was a while where like I hadn't been diagnosed yet. Actually, it was Dr. Jasper's sister, Dr. Josie, that diagnosed my
endocrinologist.
My diabetes, and she had told me at the time that it's sometimes you don't realize that you have it because that would be like a clear sign right away, but with back pain and an injury, it'd be harder. But with me, I'm constantly looking down at my feet. I have to check to see if I have socks on. I have to check every time I go into the shower, I have to look down to see if I've taken my socks off or not because I can't feel them. And a lot of the times, this is weird, the socks just come off my feet because I guess without feeling, your foot loses like a tactile grip.
Yeah.
And so I'm constantly losing a sock. So it's not strange for me to put shoes on with one sock on and one sock off.
That's a common mistake, error that some doctors do, and patients. Like I get tons of patients come to my office with coming because they have back pain and pain going down to their knees or something, and then I look at the MRI and I see that they got some nerves are crushed and they're going, L5S1, the nerves are getting crushed. And I look at the patient and say, do you have any pain in your feet? Oh yeah, but that's diabetic neuropathy.
Right.
I said, well, it could be pinched nerves at L5S1. Oh no, that's diabetic neuropathy. Completely, like you ask the history, don't even talk about the pain that they have in their feet because they got diabetes. And I can't tell you how many patients I give them a bilateral transfemoral epidural at 5S1 and all that pain goes away.
Yeah.
And I said, now what is it? Well, I guess you're right, doc, but they get it in their mind that it's diabetic, and that we talk about that here.
Yeah.
And we've on the show, quite a few patients will come in and say, you know what? I read my MRI report and it says I have pinched nerves at L5S1. Maybe I don't have diabetic neuropathy. And we treat it and it goes away. Not all of them. Some of them have the combination.
Right.
It's not always. There's a concept in the orthopedic world of double crush. So it's not always one thing or another, and there can be even like both. Certainly there are some people who have herniated discs in the back, stenosis in the back, and the diabetic neuropathy. So I think it's
the trifecta.
It's important also that yeah, don't just sort of self-diagnose as a patient. And certainly if you're having back pain or pain kind of outside the foot, symptoms outside the foot, that probably is not diabetic neuropathy. It's probably worth checking out the nerves, and getting a look.
But the days with like, you know, WebMD and Wikipedia, people are always self-diagnosed. My wife is famous for that, self-diagnosing herself.
Well, because of the internet today.
Yeah.
But that's interesting. You don't hear much about a double crush syndrome, and I learned that years ago.
Yeah.
And some doctors agree, some doctors don't. But I agree with it, and I based on my own experience in my practice, I've decided that most of the time I'm going to do, if a person has two levels that have pathology, I'm going to do one at a time, because there's a very high chance in my practice or in the history of my practice where you do one level and all of a sudden they have no symptoms from the other level. That's double crush. If you have two nerves that are crushed, you relieve the pressure on one. For some reason, the other one, it's a phenomenon. I don't think they ever figured out why. I mean, is there an explanation of why? It just happens. So to go get a fusion at 4 levels, because you have some pathology, and I've seen it, and I'm sure you've seen it too, Chris. I mean, the patient's like, "You want to see my MRI before?" I said, "No, I don't want to get pissed off today." I started seeing the MRI, and they got little teeny bulges at 2 levels, and one's a little bit bigger, and then they got one that that's the one that might be the problem.
Right.
You treat that one that you have diagnosed as the problem based on your symptoms, the MRI, and maybe doing an epidural. This is what's great about working together as a team, where we could do epidurals. And you know what? I think every surgeon, I said it before, every surgeon who does spine surgery should know how to do a transfemoral epidural. And I've taught quite a few surgeons, and it's a tremendous diagnostic technique to figure out what level you want to operate on.
Yeah.
Yeah. So we're going to be doing a lot of that stuff.
The challenge, I think, from the surgeon's perspective, is that going through spine surgery is such a big kind of rigmarole for the patients. You're going to the hospital, you're under general anesthesia. And so people tend to say, well, I want it all fixed when it's there, because I don't want to, I don't want to come back and have it happen again. It's different, though, if you can assure the patient that, well, this isn't going to be that invasive. We can maybe even do the surgery. One of my friends does a lot of surgeries awake now, where the patient gets a spinal, and it's a big thing now to try to improve safety, and it's done under local. And so there are certainly like times and ways that that if you minimize the damage from the surgery and minimize the amount of trauma, maybe it's not that bad to have to come back in a few weeks or months to get the second, third level done.
Yeah, that's the way to go, because like I said, I've seen it so many times. I had a patient a few weeks ago, had 3 bad, every level was moderate stenosis. One was a little bit worse. And the pain that they had was in that area that you would suspect to have that. If you crushed the nerves of that area, you would have that kind of pain. I did that. They came back, and they came back 3 weeks later, and the guy says he walked 5 miles. I said, I told you to take it easy. He says, Doc, I had no problem. And he said, when can we do the other one? I said, why would you want to do the other one? I said, you have any pain? He goes, no, I got 3 bad levels. No, we're done.
Yeah.
That's a good reason. And this is one of the reasons why I'm not really complaining about the insurance companies will not allow you to do another level for 90 days.
Oh, yeah.
And I tell them, I said, listen, we got 90 days. I can't do anything anyway. If you need it, we'll talk about it. And I see my patients after these surgeries once a month, just to follow up for retrospective studies, to publish stuff, to make it easier for the insurance companies to pay for the ones that aren't paying for it.
Right.
Yeah, I mean, as long as people realize that, look, you might have to come back for a touch-up, that's not the end of the world. That doesn't mean we should have done it in the first place. It just means that sometimes you need a second look. As long as people kind of are okay with that, I think it's totally,
and they
totally
should
doable.
be.
Yeah.
And they should be. And they need to understand that. They need to understand that, and I always say it, and you said it in different words, and I said it earlier, there's no such a thing as somebody with a bad back, bad neck. I want to get it fixed once and for all so I can live the rest of my life pain-free. It ain't going to happen.
Right.
It ain't going to happen. It might mess you up more than anything else.
Yeah. And those patients that say, "Oh, just fuse me then, fuse me." You know, you don't want to end up with your back like a broomstick. You know, that's not the one and done, because that's the big thing. They all want that one and done, don't they?
Yeah, I had a patient the other day that came in with severe pain down his leg.
Mm.
He went to a doctor who, I don't work this way. Maybe I'm going to get in trouble, but he went to a doctor, young guy, you know, he's like 35 years old, and he had a big herniation at L4-5. I could see it right now in the MRI, and it was on the left side because it's on the right side on the MRI, and it was crushing the nerve, the traversing nerve root that goes down to 5, and pinching off the number 4 nerve root.
Yeah,
right. He had it going all the way down into his toe, right, and he went to a doctor, and they did an MRI. Doctor found it. He sent him right away to, and I don't agree with this, but probably most of them do it because of the insurance company. Send him right away to physical therapy with severe sciatica pain and put him on a Medro pack. And this doctor knows how to do epidurals. My practice, I see that. The guy is limping. He can't walk because he's got severe sciatic pain. I said, tomorrow, we're doing a transforaminal epidural. We're going to calm that nerve down. We're going to decrease the inflammation of that nerve. It's going to shrink down and pull away from the structures. Now, the guy didn't have severe pain like he did before, but he was incapacitated. He really couldn't do much. And he never had an epidural. And this has been going on now for a month. He said he went to physical therapy for 2 weeks. He said that it was so bad he had to quit. So I said, listen, I'm going to book you for it. This might have to come out. But he was a young guy. This might have to come out. He had no weakness, thank God. Otherwise, we would have had to move quicker. I said, I'm going to give you a transforaminal epidural to that area, which is going to directly bathe that with the steroid, not taking it by mouth, and it goes through the liver. And then the liver metabolizes. You only get 1/4 going into the bloodstream, and it goes all over the body to get a little bit by that nerve.
Yeah.
I mean, that's ridiculous. You get side effects from that. But the other doctor's probably worrying about the insurance company, number one, won't want to pay for it, the epidural.
Yeah.
Or if it's Medicare, this guy's not Medicare, they, a year down the road, they see that you didn't send him physical therapy or did a Medro pack, they want the money back. You did not do conservative treatment. But I got to treat the patient. So, and I told him, I gave him the scenario. I said, this probably going to have to come out, but it's not a rush because you have no weakness. All right, you got pain. We're going to try to control the pain with the epidural. If that pain goes completely away, and I've seen this, and I'm sure you've seen it too, MRIs a year later, the previous herniated disc is no longer present. For some reason, the body eats it up, takes it away.
Yeah.
But he has no weakness. That's the key thing. If you have weakness, you got to move on it. Otherwise it could be permanent weakness. Yeah. So I explained the guy was so happy the fact he might not need surgery, and we'll see where it goes. If it comes back, he's either in a lot of pain or he develops weakness, I go in there endoscopically with a little 4-millimeter incision, and I take it out. I might have to do it intralaminally because it's right at the lateral recess.
Yeah, I mean, the insurance companies are really getting more and more difficult with requiring what they require before you can give them definitive treatment. It's funny, one of my residents and I actually just recently finished a review. We looked at the medical necessity guidelines, which is what the insurance company thinks you should do as a patient before you get certain treatments. And we looked at the guidelines for the different insurance companies in our community in New Jersey, and so there was a ton of difference in the criteria. Some want 6 weeks of physical therapy, some want 12 weeks of physical therapy. Some say you got to have a pain greater than 7. That means if your pain is 6.9, you're out of luck. And you know, there's a ton of like, it just doesn't make any sense. But yeah, I find that's increasingly harder and harder. And you know, patients, I mean, there's no way you would know as a patient, you know, when you're signing up for some insurance company, I'll get in trouble here, you know, Aetna or Horizon or whatever, that like they have these kind of restrictive rules in the back end that might somewhat tie the doctor's hands.
Mm. I don't know. I cut my nose off to spite my face sometimes, but I treat the patient, and I guess I shouldn't, and that's how most doctors do it. They go by the book as far as insurance companies, but I could never see myself treating that patient the way that other doctor did.
Yeah. Even getting the MRI is often difficult. They usually want 6 weeks of PT before they'll approve an MRI.
Imagine that. I get
Yeah.
on the phone. I said, I want a peer-to-peer review with a doctor who's making this decision.
Yeah.
And I get it. And probably 9 out of 10 times, you're like, you know what? You're right. Absolutely. I don't care what they say. I'm going to prove this. 9 out of 10 times. But you always get that one guy saying, listen, this is what I do. I got to read it to you. I'm here to read you. You need to do this, that, and this and that before the patient. That's what the patient, all right, does the patient have weakness? No, but the patient's in severe pain, can barely walk.
Yeah.
And it's classical symptoms of radicular pain from pressure on a nerve. We got to find out what nerve it is and treat it. No, you can't do it. It's got to be 6 weeks of physical therapy. How do you tell a patient that?
Yeah. So I actually looked this up recently. So Horizon in particular has an exception criteria to get around the 6-week physical therapy requirement, but you have to say that the person has 9 out of 10 pain in a nerve distribution, an L5 or whatever. You have to say they have severe functional loss at home or at work or both, and that they've tried at least 7 days of some conservative measure. And then you have to be either an interventional pain specialist or a spine surgeon and say you're contemplating a procedure depending on the outcome of the MRI. But that is it's like I have a template on that I'll like kind of throw in my note if I think that's the reason I'm ordering the MRI.
Can you fax that to
Of
my
course.
office, please?
That is if you hit those buzzwords, again, if you just hit the right, it's semantics, but if you say those words,
we say that without using those words.
Yeah.
And then you got somebody who is non-educated.
Yeah.
Reading these things. When I say non-educated, they're reading and looking for keywords.
Yeah.
If they don't see those keywords, they deny it.
It might be a computer now looking at it. I think a lot of that stuff
They
is
scan it. They scan the words. If it's not there,
Yeah.
you're denied.
Yeah.
Yeah, it's ridiculous.
What do you think about sacroiliac joint, Dr. Jasper? What's your thoughts on the SI joint?
Well, the SI joint, I tell you what, I'm pretty good at diagnosing pain.
Yeah.
And I'm glad you brought that up, because that has to be the hardest pain generator to diagnose.
Yeah.
Strictly the hardest. And they're coming out with these SI joint fusions, and they're getting paid good money for it. And I'm not saying it's bad, but listen, I'm an honest guy. I do stuff I don't do anything in the gray area, and I don't want to do anything to harm the patient. And I've gone to probably 2 or 3 different courses, cadaver courses, and different companies with different ways of putting that side, and they're pretty easy and the fusions, and they're non-invasive, and one thing good about it is if you do a fusion in somebody with SI joint that you diagnosed as SI joint pain, and you do a fusion, and all of a sudden they come back with the exact same pain, because that's what happens most of the time, you didn't hurt the patient.
Yeah.
As long as there's no complication during the procedure. And that's the only thing I really like about it. But these companies, they teach you how to do it, and they call me up and they come to my office, they bring me lunch, and they say, how come you've never done a SI joint fusion? I said, because I cannot I got a busy practice, and I'm sure there's a lot of them out there, and I'm pretty good diagnostician, but I cannot with a clear head find a strict SI joint pain that I think is going to go away when I do a fusion.
Yeah.
But there's a lot of guys doing tons of them.
Yeah.
It's hard to, and not only hard to the main way of diagnosing an SI joint, you do your maneuvers and everything, physical examination, which would suggest it, but you do an SI joint injection, and I'm pretty good at it.
Yeah.
When I put a needle, if I got to put a needle somewhere, it goes where I want it to go. But the SI joint is very difficult to get it right where it's supposed to be. Why?
Yeah.
Because the SI joint is not a straight joint, right? The posterior part of the joint When
It's
you
like an
look at it,
S.
it
It's like
looks
an
like,
S.
yeah, it looks like the anterior part.
Yeah.
So half the time you don't know whether you're looking at in an X-ray, whether you're looking at the anterior, posterior. But you can figure that out by maneuvering that's only one problem, and it's curved, so it's not
Yeah.
straight like doing an AC joint. It's right there, boom, you put it in. But not only that, half of it's fused. The best part to put it, you put it in there, and the dye doesn't go throughout the SI joint because at that area might be fused.
Yeah.
So it's still even hard to diagnose that. I mean, what do you think about it?
Yeah. So, I was, I mean, the SI joint is a junction between the spine and the pelvis. Like,
Sacroiliac joint.
yeah. And it's kind of under that dimple that people have on their like low back, just right below where the belt sits. And so, probably about like maybe 8 years ago, 9 years ago now that SI joint received increased popularity in the surgical world because of some new technology that came out. And I was skeptical, and I didn't really do it or try it for the first probably 4 years. And then back in the past times, people would take hip bone to help with spine fusions. Hip bone is still the gold standard, still heals really well, but it hurts and it can cause pain and damage in that SI joint. So I had a patient who had like a clear SI joint problem, even on imaging, which you can never see, but you could see because they'd had a hip bone harvest, and they had had a couple of injections. They were miserable, and so the diagnostic workup is you're supposed to get 2 injections, like Dr. Jasper said, under X-ray, and you're supposed to get more than 70-80% of relief temporarily following the injections, and that's how you kind of confirm the SI joint's causing the pain. There's some tests you do on exam where you take the person's leg and rotate it and move it around in a couple ways to try to provoke and see also. And physical therapy can work, and I think chiropractic adjustment can actually work pretty well for the SI joint also. So anyway, so this patient, so I did all that, had a couple injections, and then I went and did an SI fusion on him, because they were kind of at wit's end. And that person was like one of the happiest patients I've ever had.
Yeah.
And like my colleagues do not think highly of SI fusion and don't do it very often. So it's just funny because, I remember this patient in the waiting room, like, oh, that's Dr. Radcliffe. He did my SI fusion. And I was like, could you not say that? Could you just,
No,
but
when you get,
I've done a couple over the years. I mean, and I will say it, I mean, for the properly selected patient, I mean, it makes a ton of difference in their life. They're really better. And it's a great, procedure.
yeah, and they have some new techniques for SI joint, extremely minimally invasive. I say almost quasi non-invasive. But these new types, the insurance companies aren't paying for it, so they're kind of forcing you to do the more invasive ones.
Yeah.
None of them are really invasive, but the from the side, I think you have to come in from the side, otherwise it won't pay for it. But then there's a company that came out recently. One of my reps are telling me that they've modified the posterior approach with one more screw coming in from the lateral aspects, which should be covered by that by the insurance companies now.
Yeah, I've done it from the side. You do have to split the hip muscles, and people often have pain and even weakness temporarily in the hip muscles after that. I mean, it is the most direct way to get to the joint. You're perpendicular to the joint. I think you get good like kind of positioning of the screws and things like that. There are a couple of less invasive ways to do it, going from the back, um, as well. And I mean, I would agree. Like there's a way to do it where you put a piece of bone in the joint from the back, to try to make it fuse. I'm not sure how well it works, to be honest with you, because to get fusion, you really need stability plus bone grafting, and you have to kind of like prepare what's called, but I don't think it burns a bridge. And I've had a couple of patients who, for whatever reason, they got the bone graft put in, piece of bone graft put in, it didn't work well for them, it didn't heal it, and it's not a hard you don't burn a bridge. It's not a hard revision.
You actually
Just do the
haven't
traditional
hurt the
surgery.
patient.
Right. So, I think that's important also. If you're going to do something that's like a maybe work, maybe this doesn't work, you don't want to like do it in such a way that you're preventing future, corrective surgery if they need it.
That's what's good about these new minimally invasive procedures for spinal stenosis. People like, well, is that gonna be permanent when you put that space in? No. If you get worse in the future, or if it just doesn't work enough, we could just pop it out, and we can have Dr. Radcliffe open it up more efficiently at that point, if need be.
Yeah.
I wanted to. I don't. Do we tell the patients out there that are listening that want to get in touch with you? How do they actually get in touch with you?
Yeah, so I'm not gonna go live until October 1st. My last day at Rothman's September 30th. And after that, I've got I'm gonna have my website will be spinaldisccenter.com. My number will be 609-800-DISC,
Huh.
609-800-3472. And then my email address is going to be doctor@spinaldisccenter.com. And I can certainly get you that information to put online. And
When are you going to put people now that they know your name could Google you, and when will that be live as far as they'll find all that information on Google?
Yeah, sometime in the next the next couple weeks. I'm sort of just trying to get all that stuff in line. Google, Health Grades, Vitals. There's so many so many companies that make money off our information.
Yeah.
And so I'm going through every one of them. It's interesting. You have to it's called claim your ratings. You have to tell them who you are. And I'll tell you, some of the companies, Dr. Jasper alluded to this earlier, but some of the companies it's a little sketchy. But like if you as a physician pay them, you can hide bad reviews. So it's true that you can't totally believe the reviews that you see, because the docs can kind of conceal some reviews, if they're not if they're not favorable.
I got a really bad review, and I'm very upset about it, and I can't get it off. You want to hear what it is? Patient complained about the fact they had to wait long in my office.
Yeah.
It said that especially don't come in at 11 o'clock hungry, because around 12 o'clock, somebody in office starts cooking spaghetti. You smell olive oil and garlic cooking, and everybody's salivating in the waiting area. They torture you, and I didn't go in until like 1 o'clock. I could see they were busy, they were running out, but we were being tortured out there with the smell. It smelled like an Italian restaurant. But I can't get that, for some reason. I can't get that off of the thing. They gave me a negative review. Jesus God, what are they gonna do?
Just have people go online and comment about how good the food was, though.
That's right.
Yeah. But the only bad reviews I ever get, well, thank God, I would be nice I didn't get any, but are the reviews about waiting long.
Yeah.
And if you want to go to a good doctor who sees their patients, and all the stuff we talked about today about how to explain to the patient about their disease and how it's going to be treated, you go over in front of the patient. We go over in front of the patient, the MRI. When a patient leaves my office the first time, they know how to read an MRI better than most doctors. Yeah. Because most doctors don't do it.
Yep.
They don't do it. They read the report like we talked about, and they know the sequence of events, the protocols, and the steps that they can get to feel better. And some people are quick, some people are longer. You have to accept that, and you got to look at it this way: if a patient calls my office in severe pain that morning, I'm going to see him that morning. I'm not going to see him 6 weeks down the road.
Yeah.
And what would you rather do? Would you rather be a patient that has to be in severe pain for 3 weeks to a month or 6 weeks to see me, or get in that day and maybe the week after I see you to go over the MRI, you might have to wait 2 hours? It's not always like that, but that's what it is. And patients always say, I would rather get in here right away. I usually calm them down.
Yeah. I mean, two things I've found is, number one, especially since the pandemic, people are also much more willing to do telemedicine and touch base on the phone. And so, I think that to some extent, just coming to the office just to review the MRI, if you kind of know what the MRI is going to show already, I just call those people and, save them a copay, save them from having to check in the office, and just say, look, it's as we MRIs, as we discussed, what do you want to do next? We talked about the options, and I think people really appreciate that and that respect for their time. But yeah, I mean, at times, sometimes you're gonna, there's gonna be delays and waiting, and it's hard. It's just that you're like Dr. Jasper said, like you're just trying to be available for other people in the community, and certainly, as a patient, I mean, you got to think about it that way too. If you call up and have some emergency problem, you're going to want to be able to get in and kind of get seen, even if you're not otherwise on the schedule that day.
Being a patient myself, I've been to, before I met Dr. Jasper, I've been to like every pain management physician locally, and you're writing off the rest of your day when you go to those guys. The great thing I found about Dr. Jasper, and I do tell the patients that flag me down and stuff, is when you're sitting in that waiting room, at least okay, that this man is going to take care of you, and there's a good chance, a very, very good chance, you won't have to suffer pain anymore. Now that I'll wait for all day.
Well, I have less and less people leaving the office for waiting too long.
Yeah.
Is because they start, before they decide to leave the office, they start verbally complaining.
Mm.
And so many patients of mine come in and say, this next guy coming in here, he's been complaining the whole day, but I talked him into staying. I said to him, it's worth the wait. It's worth the wait.
It is. It
And
is.
then they come in and they say, you know what? I'm glad I listened to that person.
And when you're sitting in the waiting room and you're getting annoyed about the wait, you got to understand that the patients in there are getting all that individualized care that we've been talking about during this show. Right with Dr. Jasper, he's explaining all this stuff, and he's going to be doing the exact same thing and spending the exact same amount of time with you when you get in there. And so when you're in the exam room with Dr. Jasper, it might be worth your while to really just think about the time he's spending with you. And that's the reason why you were sitting out there, because the time he spends with you is like gold. It really is, because this guy is telling you your path to recovery.
Yeah.
And that, what's the old vodka commercial? That's priceless, right?
All right, so Jerry, let them know where we can be found.
Okay, yeah, we can be found on Facebook, YouTube, Rumble. After our live shows, I post everything up on the podcasts. So on venues like Spotify, iTunes, Yahoo, Google, even Audible, you'll be able to find our shows nicely archived and all of that. But remember, like we try to do our shows as often as we possibly can. These are surgeons, by the way, so sometimes their schedules are a little awry, so it's not always every week. But when we do, it's important for you to like and subscribe to our YouTube or our Facebook channels. So when we do go live, you'll get a notification and it'll tell you that we're live and you can join in. A lot of you who are meeting Dr. Jasper for the first time, this is a great way. This is a great introduction. So you can have your questions ready for us. You can text them into the chat. And in future, we will make sure that the phone lines are available so you guys can call in. And you can find out if this man can help you. And I'm sure he can, because he changed my life. And I know he can change yours.
So the radio show too, right?
Yeah. We're also on Cat Country 104.1 FM. On Sunday mornings from 6 to 7, and then there's another one of our sister shows from 7 to 8. So that's a great 2-hour block there of great medical talk.
So is there anybody on that other hour show?
Yeah, but I think Barbara Schneider. That's right. Yeah. So Radio Free Tom's River with Dr. Barbara Schneider, who's usually next, but she wanted to have a nice weekend off.
I got a question for you. If someone's outside of the listening area, Dr. Jasper, but they want you to look at their MRI, will you do that?
Absolutely.
Take a look. Yeah.
I looked at somebody's MRI the other day from where the heck, from Colombia.
Yeah.
Right.
And the guy's going to come. He's going to come.
Yeah, and same thing. I've looked at people's MRIs from Hong Kong, from UAE, from all over the world also. So, you know, if you're listening to this, but even if you're outside of our area, don't think, oh gosh, I can't benefit at least from these guys' insight or, you know, or experience or thought, because you can send it in and we'll certainly take a look.
We have a program in my practice, and you probably like that too. Anybody can send in their MRI.
Yep.
And when I hate to say free of charge, you know, no expense to the patient.
Yeah.
You send it in, you can even mail it to us.
Yeah.
You can email it to us, get it to us, and we will review it. And if we feel that we can help you, we'll call you.
Yeah.
And this is all, you know, gratis. I mean, we'll call you and tell you if we can help and how you, and at that point, then you'll have to make an appointment. And then we'll go into more detail on how we can do it and actually act on it.
And I got to tell you, when Dr. Jasper does act on it, okay, it's life-changing. It changed my life. It changed my family's life in ways that I have spent the last, you know, decade or so explaining to him how absolutely grateful I am, because how many guys do you meet who not only changes your life, but gives you purpose, you know, working with them and stuff. And it's been an amazing joy for me.
And you've been a great asset to the whole practice now, also helping Dr. Radcliffe.
Yeah, that's great. Thank you.
By the way, you can call us at 732-262-0900.
It's up on your screen right now. And so we've been running for about an hour and a half almost. Yeah. It's an hour and 21.
Time flies.
You didn't tell them where we're located yet.
Yeah, 74 Brick Boulevard. It's right across the street from the Stop and Shop, right behind the Roy Rogers in the pavilion there. We're building number 3. And believe me, if you guys live even a little further away, it's worth the drive.
Well, you know, we're in a good location.
Yeah, we're in a great location.
We're 5 minutes off of the Parkway, exit 89.
Yeah. So I guess that's it, right?
Yeah, well, I've had a good time.
Great.
Thank you very much, Dr. Radcliffe.
Yeah.
Thank you for
We're going to have a great future together.
Thank you.
And the patients.
That's right. You guys take care. For more information about Dr. Jasper and all the wonderful things we talk about, please go to jaspermd.com.